privilege to invite my co-chair, Dr. Alex Nemitz from Vodafone. See, it will be very interesting to hear him because now we are all graduating more and more towards M Health. So I think we look forward to his presentation. Dr. Alex Nemitz.
Thank you very much, B.S. I would like to build on what we just learned from you, Frank. You gave us a tour d'horizon of all the international organizations that are involved in this telehealth, e-health, m-health space. And I would now like to build on that and share with you some international examples. Today I take a different one. Let me pick this one. Thank you. I take this one, please. Here we go. And I can start it right away. This morning I was extremely impressed when our chairman, Rajendra, shared with us the fact that in India, 65% of the population, if I'm correct, are living in rural areas. It was even 70% of the population are living in rural areas, and only 2% of the doctors are living in rural areas. That's a big challenge. And the 4 examples I brought to you partly touch on this challenge, because India is with such a challenge not alone. And I will share with you 4 examples. 2 come from emerging markets, developing markets. One is Tanzania, the other one is South Africa. And then I will share with you 2 additional examples which are coming from developing markets. But we heard it this morning as well, the limits between developing and emerging and mature are blurring. So let me dive into the examples straight away. Some of you might be familiar with an example we brought to life in 2009. It's a situation in Tanzania which is actually very unfortunate. In Tanzania, you have a situation where every year 80 or 90,000 children are dying from malaria. Now comes the big but. Enough malaria tablets are present in the country. It's just a logistics challenge. So when a mother with her child comes to one of the 5,000 clinics in Tanzania, and the doctor or the nurse realizes that the child is suffering from malaria, and no malaria tablets are present, then it can be too late if these tablets arrive 1, 2, or 3 days later. So what we did is, jointly with Novartis, we established a very simple project which is called SMS for Life, where the nurses now send every Friday a text message to the central warehouse, and they say how many tablets, malaria tablets, are left in the warehouse. And by doing that, the distribution network in Tanzania is for the first time in a position to have some transparency about the stock levels in the different clinics, and the patients and the people in Tanzania are also extremely happy. It doesn't work as simple as I describe it to you. That was the short version, but I only have 15 minutes. But before elaborating too much on this, I wanted to share a video with you which speaks for itself.
I'm the district malaria coordinator in Lindi, a beautiful region in the south of Tanzania. Beautiful, but with a tragic history. Malaria is the biggest cause of infant mortality in the country, with up to 90,000 people dying every year. The sad truth is that malaria can be treated if the medicine is readily available. Unfortunately, many health facilities run out of these life-saving medicines because of the lack of modern stock management. Take the case of Adija. Like many mothers, when her daughter fell ill, she walked a long way from her village to the dispensary, but when she arrived, there was no medicine. To address this problem, Vodafone partnered with Novartis and the Ministry of Health to develop a solution called SMS for Life. Every week, the health facilities are reminded by text to update their stocks of anti-malaria drugs online. This allows me to see which facilities are in need of restocking, and I can arrange for the drugs to be dispatched immediately. Already, we have seen the number of health facilities running out of stock reduced from 90% to 6%. so successful that the Ministry of Health is rolling it out to all 5,000 health facilities across the country. Hopefully this system will give all children the access to malaria treatment when they need it. A text message can seem a small thing, but here in Tanzania it is helping us with a giant battle.
The gentleman in the video spoke about the upcoming rollout. Actually, the rollout is now history. The video was prepared earlier this year, and after an assessment of this project, and Frank, you spoke about it earlier, there are many projects, but not that many survive. The results of this little exercise were so remarkable that everybody decided we want to roll it out across the country. And in October, all the 5,000 clinics in Tanzania are now covered with this SMS for Life system, and it's working extremely well. Let me only share one secret behind that with you before I go into the next example. The secret here is that you also have to think about the incentive systems you provide for the people who participate in this. And the nurses who submit the information every Friday to the central warehouse via SMS, they receive as an incentive some free voice time or text messages. And when we did the pilot, we experienced a situation where the compliance level dropped within 2 or 3 weeks from 95% to less than 70%. And we didn't have a clue what was going on. And then we learned that the incentives were not distributed to the participants. So it's a little thing, but it has a big impact, and you can move quite a couple of things with text messages alone. The next example I would like to share with you is an example from South Africa. In South Africa, you have a situation which might be to some extent comparable with India. In South Africa, you have too few healthcare professionals, and you have, in order to bridge the gap between the lack of nurses and physicians, you have so-called CCGs, community caregivers. You have about 100,000 CCGs in South Africa. And to my knowledge, in India, and apologies for my pronunciation, you have the Anganwadis, which I hope it's understandable with my pronunciation, who have some similar tasks, I heard. The CCGs in South Africa, they go and see predominantly the elderly and the HIV patients, which is a big challenge in South Africa. And they provide care and advice to these people. They provide them some medication. They arrange meetings with nurses, with healthcare professionals in clinics. And in the past, the CCGs in South Africa, they wrote reports with pen and paper. And these reports were aggregated every 3 or 6 months to a regional, to a national level. And then on the national level, you could see some CCGs see 5 patients a day, others see 10 patients. But by the time you received this information, you couldn't draw any other conclusion from that. What we did last year is we provided in a pilot model some CCGs with, I'm not sure if it's inappropriate advertising here right now, with Nokia smartphones. It worked very well with Nokia smartphones. And the CCGs now have a chance to record a patient record line on their smartphone. So they go and see the patient, and in South Africa, patients have a small booklet with, on the back side, a 2D barcode, which talks about the medical access opportunities. And they identify the patients with a 2D barcode, and then they immediately have what I would call a patient record line of the patient. So they see, I saw this patient 2 weeks ago, 6 weeks ago, the patient suffered from this or that, and they also see a little bit more of the history. Then when they serve the patient and provide him information, they can quickly, with a download menu, include it in this patient record line. And the information is immediately aggregated on a regional level, on a national level. This does not only allow right now in South Africa to have a much better transparency on what people are doing, but it also allows for a very quick detection for epidemic outbreaks. For instance, in some parts of South Africa, if you realize via this activity level reporting that flu medication is very much needed in one area, And the project developed in a very nice way. We started with some 50 to 100 CCGs. It expanded to 300. And by the end of this year, the aim is to go towards 1,200 CCGs in South Africa. The CCGs also appreciate one additional thing. By using this little device, this smartphone, they also improve their skill level. Because in the system, they learn about new terms which are used in the medical arena. The next two examples, which I will quickly cover, are now from the so-called mature markets. But maybe there's also something in it which could be relevant for more emerging, developing economies. In Greece, we deployed in 2006 a system which is a connection between GPs on the island and specialists in a hospital in essence. You have in Greece not rural areas as a challenge, but the islands as a challenge. So if a patient on an island suffers from a specific disease, he needs to travel in order to see a specialist by boat to a hospital, say in Athens. In order to compensate for that, we prepared a little suitcase with 8 devices, a spirometer, additional devices, which is given to GPs on the islands. And now the patients can see the GP on the island who takes the measurement and then transfers via a smartphone the results to a physician in a hospital in Athens. The agreement is that the specialist returns information within 24 hours. In reality, it happens very often within 5 minutes. The patients are very happy, the GPs are very happy because they can also improve their relation with the patient. And the project is working so well that it developed from 3 islands to 17 islands, and now we are expanding to 30 islands across Greece. A last example from a more mature market is coming from the UK. I'm not sure if anybody is present who is from a hospital chain here. One person. Maybe this could be interesting for you as well. We have a situation in mature markets very often where patients are too often actually in hospitals. In emerging markets, the challenge is slightly different because the population growth is so immense that the hospitals can't adapt with building their infrastructure accordingly. What we did in the UK is patients who suffer from an immune deficiency receive every 6 months an intravenous infusion. And in the past, they received it in the hospital. They had to stay for a full day in the hospital to receive the infusion. We said, you can also receive the infusion at home. We sent a community nurse to your home. The community nurse puts in the needle in your arm, and then via a smartphone, and the nurses actually developed the software. Well, they didn't develop the software, apologies, they developed the menu and the questions behind it here. Via this software, the patient stays in contact with the nurse in the hospital and the physician in the hospital. And the patients highly appreciate it because they don't need to travel to the hospital anymore. They can stay in their own environment, have more freedom and independence. And this is an application where the infusion leads in less than, I arbitrarily pick a number, 0.1% of the cases to side effects, so the risk is very limited. And it's a service which is highly appreciated by patients and by physicians. But in the UK, we had to adapt the reimbursement model accordingly. So every country is different in the healthcare systems, and you need to find the right incentives here. In summary, the presentation is over. Don't send, let me try this. Maybe you can help me on that one. In summary, our view is so that solutions are ready. There are enough solutions for mature and for emerging markets that can be deployed. You can't apply mHealth everywhere. You need to pick the right indications, the right diseases, and I'm fully with you, Frank. It's not about the technology, it's about the patients. So we shouldn't talk about mHealth, we should about the patient and what helps the patient. But solutions are ready. To some extent we are in a fortunate, to another extent we are in an unfortunate situation because Vodafone, even though Vodafone is only existing since about 20 years, but we are active in the mHealth area since the 1990s. So we have a wealth of experience, which is not always something good, but we can tell you also what doesn't work. And so our mission in the mHealth area is we would like to provide the patients and the healthcare professionals more freedom and independence. And we are seeing, in light of the improved qualities of mobile network connections, while at the same time the costs are becoming lower and lower, that there's an increasing demand not only from emerging markets, but also from mature markets. Thank you very much.